Love it. Okay. So for the recording, I'll just, well, I'm not sure if it's recording my voice though, is it? It should be. Okay. So this is the wrist and forearm lecture. The hand lecture will be later for you listening in. Okay. So here's the anatomy. We just talked about that. The left picture is your palmar or volar side, and the right picture is your dorsal side, or posterior side. So you can see the nerves that come through. That's the main thing I want you guys to be aware of is, excuse me, I said that wrong. They are both palmar. They're both palmar sided. So I don't have a picture of the anatomy of the posterior side, but look that up. Okay. But one is showing more of the median nerve and one's showing more of the ulnar nerve, which is what I wanted to, you guys to appreciate there. And so on the picture on the right, you have to understand the ulnar nerve innervates most of the hand intrinsic muscles as well as the thenar eminence. And so it's involved in thumb adduction. And so that's one test you can do that is weak if the nerve's involved. And then you also have Wartenberg sign, which is when your fifth digit sneaks out and just kind of sits out there all the time into abduction. That's another test. So you can see maybe why. So as we move on, here are the bones of the wrist. And for this lecture, you're going to focus on the proximal row of carpals, as well as the distal radius for the most part, outside of the nerves we just went over. Here's a better view of kind of the wrist and forearm complex. And what I want you to take note of here is just the ligamentous stability that's involved here. And also the interosseous membrane, which is very important. The differential diagnosis for the wrist, we can sprain our wrist very easily without a true, not a true big traumatic injury. So you can see all the ligaments that are there. You can tweak those. And so our differential has to include wrist sprains in most of these cases. All right. So bony injuries. This is what's called a fall on outstretched hand or a FOOSH injury. I'm sure you guys have heard of that term before. Something like a kid riding his bike who falls, playing on the monkey bars. You don't have to worry about the picture on the right down here, but I do where I'm at. Every year we get people come in with fractures from falling and slipping on ice, patellar fractures or things like that, you know, if they lived somewhere else, it would never happen to them. So it's just unfortunate. But this is the situation, okay? Falling on an outstretched hand. And you can see how that mechanism we talked about earlier may induce an elbow dislocation, right? Or a fracture or whatever. So not good. So we keep going here. The first one is distal radius fracture. And you can just see the pictures on the right. It's any defect in the continuity of the distal radius on observation. And so what happens is the bone breaks, the distal radius breaks and creates an observable change in the contour of the arm. Obvious fracture here, right? This is called a closed fracture because the skin is not broken open. An open fracture is when the bone breaks and pierces through the skin, right? And that's a much more serious, well, they're both serious, but the open ones, you have to worry about things like infection and stuff like that afterwards. So long story short, you'd rather have a closed one. The x-rays there, what it looks like, you know, when we get radiographs, you can see the discontinuity in the bone, which confirms your diagnosis. All right. Your considerations here is that the radius is the most commonly broken bone in the arm. That's important to know. Most common fracture site in children is the distal radius, and it's between 35 and 45% of all pediatric fractures. In the pediatric population, higher frequency among boys than girls. I don't know the reason other than I maybe can speculate little boys may be more risk-seeking than younger girls are. And that's a generalization, of course, but I think that may be why. Two main types of distal radius fractures. One is called a Colles fracture and one's called a Smith's fracture. A Colles fracture is, the hallmark sign is that it's got the dinner fork deformity. So flipping a fork upside down creates the same kind of shape as a dinner fork. As this fracture. You can see the distal radius gets displaced dorsally with a Colles fracture, which creates that contour that looks like the dinner fork. A Smith's fracture is when it gets displaced volarly or anteriorly, and you can see the different mechanisms on the picture in the bottom. You land with an extended wrist. The transmission of force tends to take the distal radius posteriorly. You land on a flexed wrist, it takes it anteriorly. Can you guys picture that and see that? Okay. The signs and symptoms: pain, point tenderness, edema, ecchymosis, visual wrist deformity, loss of function, loss of mobility, all things you would expect to see with a fracture. Functional implications: obvious pain with weight bearing, difficulty moving, active or passively. Grip's going to be limited because you're in pain. You have a way to fix this through an ORIF, which you can see on the picture there, the plate and screws that are stabilizing it postoperatively. Contributing causes: maybe someone with osteoporosis, right? An elderly individual who falls. But this is always, it's a trauma. So it's a fall and outstretched hand, or it might be direct impact, or a crushing injury or something like that. Your differential diagnoses include a distal radial ulnar subluxation or dislocation, or a wrist sprain. Could also throw in there ulnar fracture, but the ulnar is not the main weight-bearing source of the distal forearm. It's the radius. Harder to fracture distal ulna unless there's you're trying to protect yourself from, abuse or something, and you get struck here, right? Forget what that's called, that fracture, but there's a defensive fractures, right? So that'd be a differential distal ulnar fracture. I do want you to appreciate the picture on the bottom left. You have normal anatomy here, where you have the radius extending past the ulna in kind of this AP view. So if you take the line, the top line says radial height, and then you take the bottom line, that's the ulnar height, you have that space in between, which is considered your ulnar variance, the distance of difference between the height of the radius versus the ulna. When you have a fracture to your radius, you will get this impaction fracture, essentially, of the radius, and the radial, or I should say ulnar variance, now is much closer. So it's one way to confirm the diagnosis if it's tough to see on X-ray. So there you have it. As we continue going, tests and measures, there's not really special tests for this, right? It's usually an obvious trauma, visual exam, you can palpate, maybe you do your tuning fork, right? Have you guys learned about the tuning fork yet? So tuning fork is literally what you think it is, a tuning fork. You hit it, boom, it vibrates, and you put it on a spot you think is fractured, and that vibration irritates the fracture site and causes pain, and then it's one tool in the toolbox, okay? But range of motion and grip squeeze is bad, and then radiographs confirm it. As we move on to scaphoid fracture, I know this print is a little small, but bear with me. We're moving on from distal radius fracture now to scaphoid. Any defect in the continuity of the scaphoid, same mechanism of injury as a distal radius, which is a fall and outstretched hand. This is always usually a closed fracture. It is a fracture that's frequently missed and misdiagnosed as a wrist sprain. And the reason that's important is because on X-ray, it's sometimes hard to see, especially if it's like a hairline fracture. The picture on the bottom right, you can see more of a clear fracture line here. right? This is what normal looks like. Looks like a peanut. That's how they describe it. And here, the peanut's cracked in the middle. It occurs usually in like middle-aged individuals, but anyone 15 to 60. And men 20 to 30 are most likely to suffer from this, actually. So we move on. This is going to be more signs and symptoms of pain at the base of the thumb, point tenderness within the anatomical snuff box. Did you guys know what that is yet? Okay, very good. Edema, loss of function, loss of active wrist or thumb mobility, muscle guarding, pain with movement, things you would experience with maybe a fracture or a sprain. The reason I put this picture on there is because I wanted to highlight in yellow there the anatomical snuff box. There's a few different pieces of anatomy there. There's tendons that go right across that area. There's the distal radius. There's the scaphoid, and then there's the base of the thumb. And so there's a lot kind of in that area actually to try and parse through, let alone the ligaments that you can't see there. So possible contributing causes, the mechanism of injury is a fall and outstretched hand and direct impact, just like the other one. Differential includes Colles fracture or Smith's fracture. Distal radial ulnar subluxation or dislocation and wrist sprain, so very similar to the distal radius fracture. You can see the highlighted anatomical snuff box in the bottom right. In the top right, you can see the vascular supply to the scaphoid. And why this is important is because if this fracture is missed, then you can have avascular necrosis to this bone, and this will never feel better and never heal. And so what happens is you may need an ORIF, a screw, to bring the two ends together, which we can see in this picture on the right here. A chronic one that was probably missed that needed immobilization to heal and never got it, and then you need surgery. So tests and measures, X-ray right away, CT scan, and MRI is what picks this up better. Most cases is an X-ray, but in people who are not getting better, they need further imaging. Okay. Clinical exam, tenderness at the anatomical snuff box, pain with wrist, ulnar, or radial deviation, pain with weight bearing, decreased grip strength, and if you have questions, refer out to a hand specialist. Okay. This is a study by Grewal et al., the missed scaphoid fracture, outcomes of delayed cast treatment. What they looked at in this study was for those presenting between 6 weeks and 6 months from injury that the initial diagnosis was missed, were they able to immobilize them and get them their scaphoid to heal? And they had good results. So what we should note is that if someone has radial-sided dorsal wrist pain that you suspect is a sprain that's not getting better, they need more advanced imaging. Like after 3 weeks, a sprain that's not getting better may not be that in this area. So they need to see about advanced imaging. What you can see on the picture on the right from this study is you have this chronic fracture on the top right picture on the CT scan, which is what this is what a CT scan looks like. You can see the peanut shape. And then after 12 weeks of casting, that fracture has healed because they've been immobilized so long to allow it to heal. Any questions about the bony stuff? Very good, makes sense, right? So we move on to musculotendinous injuries. We'll look at DeQuervain's tenosynovitis and something called intersection syndrome. DeQuervain's is inflammation and thickening of the abductor pollicis longus and extensor pollicis brevis synovial tendon sheaths, and maybe the extensor retinaculum. Tenderness with palpation, positive resisted isometric test, and thumb abduction and thumb extension. And then Finkelstein's test, one of my favorite tests, is best for diagnosis. And so you can see the anatomy on the right. You can see the two muscles in question, how they cross underneath the extensor retinaculum. And the blue is the synovial tendon sheath. And what happens is that sheath gets irritated through friction on the extensor retinaculum, and you can get inflammation and pain. So it's entrapment tendonitis from tendon friction. It's a good artist rendition there on the right. Mostly found in women aged 30 to 50 and common among individuals who perform any activity requiring repetitive hand and wrist movements. Signs and symptoms: forearm pain, crepitus. If you haven't heard crepitus, Dr. Bott has some crepitus in his knee. You should go and listen to it after class. Upper extremity pain, weak thumb abduction, decreased grip strength, things you might expect. Possible contributing causes: occupations that require repetitive use of the hand, direct trauma, inflammatory arthritis such as rheumatoid arthritis. And your differential includes a lot of different things for this. So rheumatoid arthritis, carpal tunnel, osteoarthritis, intersection syndrome, which we'll go over in a second here, infection, like a rheumatic infection, dorsal wrist ganglion. You got a wrist ganglion?
I do? Oh, yeah, I do.
I
do?
Let me see. Dorsal.
Is that what you're talking? Wait, is that this thing?
Yeah.
Oh.
Trigger finger, scaphoid fracture, right? So you're trying to figure out, you got pain right here. Did you fracture your scaphoid or do you got DeQuervains? What do you ask them? What's the first thing? Did you fall? Love it. This, you're not going to have an injury from a FOOSH. It's repetitive overuse. Scaphoid, fall on it, right? And then you have radial nerve entrapment. It could be a differential as well. So test and measures: resisted isometric testing of the thumb into abduction and extension. And then everyone should do this test. We didn't do it earlier because it's an easy one to do altogether. It's called Finkelstein's test. You're gonna put your hand thumbs up, but here, you're gonna tuck your thumb. You're gonna grab onto your thumb with your fingers, and then you're gonna ulnarly deviate as far down as you can go. You feel where that tension is, kind of right here? Someone who has a true tenosynovitis. Tenosynovitis just means inflammation of the tendon sheath. That will be very painful. Yes. Oh. So what I found on myself is I do both. My left feels fine, my right hurts, which I'm right-handed for writing.
Oh, yeah. Are you looking for pain or just like a stretch?
Pain.
My right hurts.
You may do an x-ray to rule out joint arthritis, especially in older individuals. As we move on to our other syndrome here, intersection syndrome. You can see that intersection syndrome is named because it looks like a highway intersection. The tendons of the extensor carpus radialis longus and brevis cross over under the APL and the EBP. And so the abductor pollicis longus and the extensor pollicis brevis. And so they get this cross. And when you're doing a lot of movements with your wrist and hand, those tendons can create friction. Like when you're a Boy Scout trying to start a fire, and it hurts. It hurts. The condition is common in rowers, weightlifters, and canoeists. I've also seen this in wheelchair users. Right here. Right? Signs and symptoms: tenderness, swelling, crepitus at this location, decreased grip strength, limited range of motion. Differential should include DeQuervains. That's the closest thing to this, and then maybe a compressive neuropathy. This is the difference between DeQuervains and intersection syndrome, is the location of pain. Two pictures are to help you try to differentially diagnose. The symptoms are almost identical. Intersection syndrome is more dorsal, right? And DeQuervains is more radial. Any questions? Yes.
Would you have like possible referred pain to like, if it was intersection syndrome, could you have referred pain like down to the radial side? That you could mistake it for?
I don't know. I've had one person with this. She's a Paralympian swimmer who was training very hard in the weight room and manually wheeling herself around. And she got discomfort, right? Kind of right there. And got really big and swollen actually. And it was there. It didn't refer down. And I don't know if other cases might. So it was very kind of point tender to this area. Initially, what I did was I put in this lecture, I put a neural and a vascular, I put Raynaud syndrome into this. But the last minute, last night, I took it out because that's definitely a hand diagnosis. And so you see Raynaud syndrome in the next lecture, the hand lecture. It's a vascular issue. So we'll be focusing on the neural issues here, the carpal tunnel and ulnar neuropathy. Again, anatomy is very important to understand. All the special tests we've been over today, how many times did I say, know the anatomy, what are you testing, what structures, why are you testing it, et cetera. Anatomy is super important. Carpal tunnel is no different. So carpal tunnel's here, right? You see that graphic? Let's do it again. Boom. You got the carpals, and then you have the transverse carpal ligament that runs over the top, and your flexor tendons, as well as your median nerve run underneath of that. And so it's a lot of structures in a small amount of space. And so compression to the median nerve there creates this symptom. You also have your ulnar nerve here. It's kind of housed within its own little confines there of the hook of hamate, which makes up what's called Guillen's canal. So carpal tunnel syndrome, it's entrapment neuropathy of the median nerve within the carpal tunnel. You know that? Pain, paresthesia, sensory loss on the radial side of the palm and palmar side of the thumb, index, middle, and radial side of the ring fingers. Waking up from pain in the middle of the night and numbness is the hallmark sign of this condition. In advanced cases, there may be motor dysfunction, loss of strength, that sort of thing. Nerve becomes compressed, causing ischemic damage to the nerve. It's often associated with repetitive motions or sustained positions of the wrist and hand, like typing on a keyboard, and your wrist is resting on something hard. That constant low-level compression can hurt. Unrelieved compression of the nerve can result in neuropraxia. So it's actually a pretty high incidence. 3.5 cases per 1,000 people is actually pretty high. 2.1% prevalence. It's the most common entrapment neuropathy. Out of anything else we've talked about, any kind of compressive neuropathy is the most common. It's more common in women than men. 70% of cases are female. It's 2.5 times more likely in obese individuals. Most common among people aged 30 to 60, and nearly 1/2 of cases will experience bilateral symptoms. That doesn't mean that it's causing symptoms on both sides. It means that you have this side as an isolated issue, this one as well. If you had someone with bilateral numbness and tingling down their arms, that's not carpal tunnel. That's probably cervical myelopathy. Make sense? Not radiculopathy, but bilateral upper extremity, maybe myelopathy. And maybe radiculopathy, but let's not. Can't speak in absolutes in PT school. Say that again? That's the classic. That's the classic thing, the meme of PT school. All right, so the distal wrist crease marks the proximal edge of the carpal tunnel. These are the boundaries. This is a layup test question. What are the borders of the carpal tunnel? A, all of the above, whatever. It's like, you should know the borders. You should know the anatomy. That's where we're getting out at. Cool. Moving on. Signs and symptoms, as you guys would imagine, numbness, tingling, paresthesias, waking in the middle of the night with symptoms, tenderness to percussion or pressure, which is Tennell's test, right? We didn't go over Durkin's test, but Durkin's test, instead of tapping, is just sustained pressure over the median nerve there. And if your hand starts going numb with that, then you might have carpal tunnel. So pain with wrist movements, difficulty with grasping, dropping items, fumbling with items, loss of strength in advanced cases. Possible contributing causes, and most oftentimes idiopathic. No real mechanism of injury, but risk factors compile until it breaks a tipping point and then you get symptoms. I'll let you read through all of those at some point in time. Actually, what we'll do is go over in italicized letters, systemic issues like alcoholism, which may lead to kidney failure, which may lead to fluid retention, right? Same thing with menopause. Those things may increase fluid in these spaces, which add compression to the area. You also have space occupying lesions like tumors or displaced fractures. And we'll move on from that. Differential diagnosis, cervical radiculopathy, TOS, pronator teres syndrome, traumatic nerve lesion, rheumatoid or arthritis, acromegaly. Do you guys know what acromegaly is?
Yes.
Gigantism, right? Hypothyroidism, which causes fluid retention, and then scleroderma, which honestly I don't know what that is. Do you guys? I don't know. Yeah, something with derm skin. I don't know. Okay. Not afraid to admit when I don't know. Okay, so tests and measures. There's a clinical prediction rule for carpal tunnel syndrome. And the clinical prediction rule is this. 1, shaking hands to relieve symptoms. You ever seen someone do that? Hands down. A risk ratio of greater than 0.67. I'll explain what that is in a second. A symptom severity scale, so this is an outcome measure, of greater than 1.9 points. That is something you should look up on your own of what that outcome measure is. Have you guys gone over any outcome measures yet? Lower extremity functional scale, quick dash, right? Those sound familiar? Same thing here, symptom severity scale. Number 4 is diminished sensation in the median sensory field 1, which is your thumb, and age greater than 45 years old. So if you're a 45-year-old who hand goes numb, you do this, you probably got carpal tunnel, right? So the way you confirm it, that test right here is your Durkin's test. That's Phelan's test, as you guys did today. And this is Tennell's test. The wrist ratio index, that picture on the top, is looking at the diameter of the wrist in an AP manner, as well as a medial to lateral manner. Huh? So it is calculated by dividing the wrist width by the medial to lateral wrist width in centimeters, and you get a ratio. So if it's greater than 70%, this is called a positive in this clinical prediction rule. Does that make sense? If this is 100%, if AP is 2/3 as long as the width or more, that's a positive test. So the thicker your wrist is in an AP direction is a risk factor. The APTA and JOSPT, which is the Journal of Orthopedic and Sports Physical Therapy, has clinical prediction or clinical practice guidelines rather on how to treat carpal tunnel syndrome. And so this is a screenshot from the clinical practice guidelines that may assist you if you get a case study with this for your practical. So I'd use this as a reference tool because I can tell you when I was a professor here and we had practicals on the elbow, wrist, and hand, it's like, okay, elbow, we got a couple things, wrist, a couple things. What are we gonna do for the wrist? Oh, carpal tunnel. Yeah, so you gotta know carpal tunnel. Of all the stuff, your practical is not gonna be a wrist fracture person, right? Maybe DeQuervain. It's probably gonna be carpal tunnel, let's be honest. Okay, so know this because this will help you with your practical and your exam.
Dr. Linville?
Yes.
Could you maybe say that one more time about the risk ratio index?
Yes. Let's go back to the slide. The top picture, the black picture, you can see that there's two lines that cross, right? One line is showing you how wide the wrist is, medial to lateral, and one is showing you how thick the wrist is from A to P, right? The thicker it is A to P in relation to the distance from medial to lateral becomes a risk factor if that length is over 67%. The skinnier wrist you have this way, the less risk factor you are. The thicker your wrist is, A to P, the more risk factor you are. Does that make sense?
I thought, I'm thinking like the more space you have there, wouldn't there be less compression?
The thicker your wrist is, the more compression there is. So, okay, so let's clear this up. Because there's murmuring. If you have someone with here's what you guys have to appreciate is someone, so this is a compressive neuropathy, okay? If you have more muscle, more adipose tissue, thicker bones, systemic condition that might increase global inflammation, all those things may increase wrist thickness, okay? That increase in structure creates less space for the nerve to move through, thus compressing it or being a risk factor for it. That's why that's the case.
Makes a lot of sense.
Your thinking is that the AP, if it's bigger this way, it may have more space freely to move. And that's not what this test suggests. Okay?
Okay, thank you.
Sure. The last one here, ulnar neuropathy at the wrist. This contraption of the ulnar nerve at Guillen's canal, or Guillen's canal, however you would like to pronounce it. This is seen mainly in things like hook of hamate fractures. And the way you fracture your hook of hamate is you land on your wrist, one. Two, could be from swinging something, golf club, tennis racket, bat, where you go into this forceful ulnar deviation. Another way that you can get this is through compressive, sustained positions on the ulnar nerve, like things like long distance cycling, where you're just always weight bearing on the handlebars. And it's the same symptoms you would expect with cubital tunnel syndrome. A lot of these slides are word for word what cubital tunnel syndrome slides were. You get symptoms down, you can get claw hand deformity, you can get all the things that you would expect with ulnar nerve symptoms, right? The possible contributing causes, I mentioned ulnar-sided wrist fractures, which includes pisiform, which includes hook of hamate, but you can also have a ganglion cyst. You can have ulnar artery thrombosis, which gives you these symptoms, and sustained pressure. Differential includes thoracic outlet, cervical radiculopathy, neuropathy of the median radial nerve, carpal tunnel, and the list goes on, cubital tunnel syndrome as well. Picture top right, you can see the hook of hamate, how it dives underneath. If that fractures, you can see how that might collapse in and compress on the ulnar nerve. Very good. Another test we didn't go over that we'll go over right now. Everyone have a piece of paper nearby? Turn to your partner. Froment sign. So your abductor, sorry. Your thumb adductor is innervated by your ulnar nerve. Okay? So this adductor, right? Mm-hmm. Remind me which is which.
Duck.
Duck. So this is adduction. Beautiful. When if you put a piece of paper out to your partner and have them try to grip it like this. See the picture on the bottom right? If you say, don't let me pull this paper away from you, and their finger stays flat, they're able to activate the muscles that are innervated by the ulnar nerve. And I don't want to hold the paper. If, when you pull the paper, their thumb collapses into flexion, they've lost strength in the muscles innervated by the ulnar nerve, and the median nerve is thumb flexion. So they're going to bias and try to use thumb flexion to hold onto the paper rather than thumb adduction. That's called Fromenstein. Does that make sense?
Uh-huh.
Okay. That's the end. Good job.